Yeah, please start.
A very good morning, everyone. This is Dr. Swasti Sarkar from RIO Kolkata, and today I will be presenting novel spacer filamentous knitted polyester fabric effective in lid retraction correction in thyroid eye disease. Quite obvious to say, I have no financial interest whatsoever. So as we all know, in thyroid eye disease, orbit is the second most targeted organ, where females are the more commoner victims. In this chronic inflammatory disease, lid retraction is one of the most common findings. Just imagine what pain we go through, even if a pimple pops out on our faces psychologically. We hide our faces like that. So just imagine for a second what those patients go through psychologically with lid retraction. And we must not forget about the grave consequences of exposure keratopathy associated with this disease. The aim of our study is to evaluate the functional and the cosmetic outcomes of upper and lower eyelid retraction by using this wonder novel filamentous knitted polyester fabric material as our spacer, and also to appreciate the safety, efficacy, and the durability of this spacer material. In this study, we included all patients having thyroid eye disease, having a proptosis of less than 22 millimeters, and the patients were selected in the euthyroid condition. The patients were all in the inactive stage of the disease, and the patients with a proptosis of more than 22 millimeters having the active thyroid eye disorders and with associated systemic skin disorders like Stevens-Johnson syndrome were excluded from our study. We evaluated and compared the pre and the post-operative values of MRD1, MRD2, the LPS, and the PFH in millimeters. We also evaluated and compared the pre and the post-operative photographs that we took in this course. And above all, we kept patient satisfaction. So as we are using this novel spacer material, we must be acquainted with how much to use, the measurement of it. So the formula for the upper and the lower lid are a bit different. For the upper lid, the maximum central width of the spacer material used was 5 millimeters plus the scleral show in millimeters plus an extra of 3 millimeters. From where does this 5 millimeter come from? Our aim is to induce moderate doses, and normally the upper eyelid covers 2 millimeter of the cornea from the limbus, that is 3 plus 2, 5. For the lower lid, the maximum central width used was a constant of 6 to 7 millimeters. For both the lids, the shape of the spacer material used was semi-luna, and the length for the upper eyelid was 26 to 28 millimeters, while it was 20 to 22 millimeters for the lower lid. Now coming to the most important part, the results and the observation. While the preoperative MRD1 value was a whopping of 7.63 millimeters, it came down to 4.68 millimeters postoperatively. The MRD2 value dropped down to 5.2 millimeters postoperatively, while preoperatively it was 6.37 millimeters. Just imagine. The preoperative PFH value was 14 millimeters, while postoperatively it came down to 9.88 millimeters. The preoperative LPS action was seen to be 19 millimeters, while postoperatively it dropped down to 15.66 millimeters. The postoperative scleral show became nil, and the preoperative mean scleral show in the lower lid was 3.14 millimeters, while postoperatively it came down to almost normal 0.21 millimeters. This is a small video which I'll be showing a bit later. Various spacer materials have been used to correct lid retraction, example autogenous fascia lata, banked sclera, septum. While banked sclera is a lot difficult to process and to handle, the novel spacer material is a lot easier to use. This spacer material causes not only the lengthening of the lid, but also prevents the reattachment of LPS and the inferior retractor to the tarsal plate. It has a minimum thickness of about 0.6 millimeters. So I'll conclude my study by saying that this novel material is inert, non-reacting, tissue-friendly material, so no question of graft failure. As it has a very minimum thickness of 0.6 millimeters, it is flexible, the lid thickness and the architecture and the contour of the lid are very well maintained. Thus, the FKPF is an ideal spacer material for lower and the upper eyelid retraction correction in TED. This is a video that I'll be showing. We are using the anterior skin approach, placing the material, suturing it with Vicryl sutures. This is how we prepare the material. And recently we have made some developments, that is we induce some holes in the material so as to prepare the material better, and it helps in easier vascularity post-operatively. In lower lid, we use the internal skin approach over here. We are suturing the material. So where did this idea for the material come from? I have a few cardiologist friends of mine. I once heard them using this material in ASD, VSD. We all have studied all these in our MBBS times. So they used to fix the holes by these patches. So I thought, why not try these material in, as a spacer, as a novel spacer in eyelid also.
Right. So what was the major cause in your cases, the etiology?
The thyroid eye disorder.
Thyroid eye disease, yes. Right. How many cases have you done?
30 cases till now.
Right. And how long is the follow-up?
So we have followed up the patients in 1 week, 1 month, and 3 months. It is a long study. We are still continuing the follow-up of the patients.
And the major complication you are having after this?
So among the 30 patients, only 1 patient had extrusion, partial extrusion of the material. Right. We believe that we actually operated the patient in the active stage of the disease. Right. Maybe that is the reason. We'll follow up the patients in the long term.
No other problem as such?
No, sir.
Thank you so much.
Thank you, sir.
Nice idea. Next, we have Dr. Shruti Hegde. And can we have the third presenter, Dr. Tharini is there? Dr. Tharini is there? Yeah, you can have it prepared there. Yeah, please, Dr. Shruti.
A very good morning to one and all present here. I'll be presenting a educational study that was a part of my FAMA project, a learning module for teaching clinical skills in ophthalmology, a unique approach. So basically, why did we think of this study? As many of you might be aware, NMC has introduced CBME, competency-based medical education for the undergraduates, and it's in the framework for postgraduates as well. So they have defined what to be taught as competencies, how many hours to be utilized, but how to do is largely missing when it comes to especially clinical teaching. There is a lack of structured clinical teaching, especially for undergraduates. I think we all agree upon that. There is a disconnect between theory classes and clinical teaching. To add to the woes, NMC introduced clinical postings in Ophthal in second year itself. So we thought of doing this module using these two novel educational interventions, Gagne's 9th step and Peyton's 4th step. I will tell you about this a little bit later. So what did we do? We developed the module that was the first phase, so wherein the competencies were identified, the skill competencies and the affective competencies from the CBME document. The learning objectives were framed, the lesson plan was formed, resources were listed, and finally an assessment plan. And this module was validated by 2 external experts. The second phase, the module was implemented among the first 30 students who came to our postings, and assessment was done using an OSCE. Finally, the evaluation was done by a qualitative study wherein a FGD was conducted among the students, 2 batches of FGD, focus group discussion, and faculty in-depth interviews were conducted. A tape-based analysis and a micro-interlocutor analysis were done. So what were the results and the conclusion? The module was effective in teaching skills to the students. How do we know that? The OSCE results. More than 80% of the students did well. They got more than 60% in the OSCE. Coming to the usefulness, majority of the students felt it was useful. In FGD, they said that the teaching was uniform even when taken by different faculty, and it was more structured as compared to other subjects. Faculty felt there was more satisfaction, and the module helped them to have a clear idea as to what to cover in each class. And they said this also avoided the repetition that happens in the clinical classes. Usually we ask them to do history taking and examination, and the same thing happens over and over again. So the conclusion is that designing a clinical skills teaching module needs a stepwise and methodical approach, and it involves meticulous planning. Gagne's 9 steps and a modified patents approach are helpful in designing a structured teaching module for clinical skills. So I'll show you now. These are the different competencies that are there in the NMC booklet. So we have chosen all the skill competencies. We added some extra on history taking. So instead of regular classes, NMC now wants each class to focus on one competency. So there are competencies on lead examination, anterior segment examination, pupillary examination. So this is the schedule for a 4-week posting. 15 days they have an OSCE and then the posting continues. So I'm showing one example from the module. So these are the 9 steps of Gagne. When the students come, we first gain their attention instead of directly starting the class. So for example, this is a class on visual acuity. We ask them, have they ever wondered about how the life of a blind person feels? Then the learning objectives are put. Usually we use objectives for theory classes. But here, we want the objectives to be used even in clinical classes to make it more specific and structured. Then it follows stimulating the recall from previous learning, whether they already exposed to this. So we can ask them about their class on visual acuity from the physiology from phase 1. So presenting the stimulus material includes an interactive discussion about the visual pathway. This will be mainly a faculty-based interaction, and then providing guidance. So we show them how the visual acuity is done exactly, stepwise manner. This is the step 2 of patents, and we have integrated both. Then the students perform it in smaller groups, and they perform on each other first before they are exposed to the patients, and their peers give them the feedback. Finally, the faculty assess as the students are performing, and we give them a retention. For increasing the retention, we give them where to study from, we give them the resources. So looking ahead, this is the last slide. So converting the module to a standardized booklet so that it can be used across the medical colleges in the country is in the pipeline. We would like to do a multicentric studies with other centers to see the effectiveness in a larger student population and similar modules for other subjects. These are my references, and thank you.
Very nice talk, madam. Any questions you'd like to ask? Anybody?
Just a comment that it has always been said that if you involve me in something, whatever you're doing,
It's not working. It is not working. Just press the button.
if a student is involved in something or if it is demonstrated, then that is what is going to be retained for long.
Yes.
So that is what you have highlighted in your study.
Yes, exactly.
Thank you.
Thank you.
Thank you so much. Next, we have Dr. Tharani. And do we have the next Dr. Gogate is there? Right. Please.
Good morning, everybody. My study is about comparison of generative artificial intelligence versus text-only learning ophthalmology, text-only learning among medical students. These are my disclosures. So as we all know, artificial intelligence is revolutionizing the whole medical field, and it is going to revolutionize medical education also. It can transform the traditional teaching methods. So AI-based educational tools can improve the learning experience in an interactive way. They can tailor the contents according to the individual needs of each student, whether they are better in learning or something like that, and reduce the time spent on each topic. So medical education also requires more visual and clinical skills. So the simulation capabilities of artificial intelligence can be used in such scenarios. The advantages of using ChatGPT and other large language models include increased knowledge retention, improved comprehension, and better satisfaction by the learner. Still, the contents of AI have to need to evolve more to replace the traditional textbooks. So the purpose of my study is to compare whether AI-based learning with the traditional text-only learning. The primary objective was to compare the effectiveness between the AI-based group and the traditional text-only learning group among the third-year medical students. And my secondary objective was to assess and compare the following parameters like post-learning assessment scores, time taken to learn the topic, ease of learning, wholesomeness of available information, and reproducibility of the learned material after 1 month. So this was a prospective non-randomized study conducted among third-year undergraduate medical students. So this was my study protocol. I divided the third year medical colleges. Third year medical students were assigned into two groups. So one group were given only textbooks to learn the topics. Other group was given ChatGPT to learn the topic. The contents of ChatGPT were verified by two ophthalmologists. We gave 4 selected ophthalmology topics were given, one each week. We had a pre-examination assessment. The scores were assessed, and after the learning phase, post-learning assessment was done. We had measurements for each topic. Primary outcomes were pre-examination score, post-learning score, and time taken to learn. And the secondary outcomes were ease of learning and wholesomeness of information. The reproducibility of the topic was tested after 1 month. These were my statistical tests. So we had totally 156 participants included in the study, and there was the mean age was 21 years with a female preponderance. Already there were 1 or 2 students were using textbooks and online resources for their routine study hours. So when we compared the scores, the pre-learning score was similar between the two groups. The post-learning score was slightly better in the ChatGPT group. The time taken to learn the topics in the ChatGPT group was much lesser. They took only 14.9 minutes on average to read the topic. The mean scores at 1 month assessment was found to be higher in the ChatGPT group. We found that ease of learning was also higher in the ChatGPT group. Wholesomeness of information, we found that it was similar between both the groups. So this was my result summary. So we found that the learning time was 42.5% reduced, and it was statistically significant in the ChatGPT group. Their post-learning scores were also statistically significant in the ChatGPT group. Ease of learning was also higher, 22% higher in the ChatGPT group. So there are some previous studies. In China, they conducted a web-based electronic survey saying that students are using more of AI chatbots. 91.05% are using already. They're using AI chatbots for quick access of knowledge and information. Another study in China has used a specialized ChatGPT tool that has showed that students have higher self-directed learning scores and better critical thinking scores using this ChatGPT tool. In India, we have done a qualitative survey for students using large language models. It has re-emphasized the ease of access, ready reference for clarity of doubts, lucid explanation of questions, and time-saving aspects. So the strength of my study is that I've used a novel artificial intelligence for medical education in ophthalmology. We have used both qualitative and quantitative measures to provide a comprehensive evaluation, and 1 month follow-up assessment is useful in assessing the knowledge retention of the students. The limitation of my study is that it is a non-randomized design. We have used only a smaller sample size. Ease of learning, wholesomeness of information, they rely on subjective self-assessment. So to conclude, the key advantages of using large language models like ChatGPT-4 in medical education is that we have improved learning outcomes, increased efficiency like shorter learning time and higher ease of learning, and enhanced student experience. We need to do multi-center randomized trials to validate the findings across multiple specialties. Thank you.
If I may ask a question, are you aware of AI hallucination? What is AI hallucination?
It gives wrong contents, wrong information about the topic.
Yes. So that is the major limitation when you are using chatbots and all for your.
Yes, ma'am. We verified the contents. Yet, whatever we do in ChatGPT has to be verified before
Yes. So it
producing
is
it to
still
the
in its
students.
nascent stage in medical education.
Yes,
as
ma'am.
such.
It has to. Thank you.
Thank you so much. Next, we have Dr. Parikshit Gogote. Do barriers to cataract surgery change over years as cataract matures? So.
Thank you, sir. Respected chairpersons, enthusiastic audience, can we have the timer, please? Yeah. Well, we all know cataract is the chief cause of blindness. It's the bread and butter of almost most of us ophthalmologists, and there have been surveys right since the last 25 years, and all of them show that cataract is still the commonest cause of blindness. So normally, why do people not seek cataract surgery? We say we are also great surgeons. We have patients who come to us and they become sick and they are very happy. If you are in private practice, they pay you a lot. Or, if you are in a NGO or a government hospital, they give you gifts. They are very thankful. But still, why people don't undergo cataract surgery? So there were generally 4 barriers: lack of awareness, bad service, cost, and distance, which we studied in our PSM textbooks. So our objective was why people don't undergo cataract surgery in spite of having good economic choices in the community. So here, this is a community-based study in which we did a door-to-door survey of 31 slum areas over a period of 5 years and tried to do a complete elimination of avoidable blindness. So first we went to their homes, identified them, checked them, got them to the vision center. If they didn't come to the vision center, the optometrist went to their homes to see what was there. And there they were counseled, must you undergo a cataract surgery. So here in the vision center, the cataract surgery was first given subsidized, and if they didn't undergo that, then it was offered to them free. So first we saw them in 2015, 16, and then again in 17, 18, and 19. So we followed them over a 4-year period. So this is total almost 44,000 people were screened, and in them we found, to our surprise, in Pune, which is supposed to be a fairly well-developed city, there were more than 1,000 cataracts. So they were given health education. So in 2017, we found 474 still had cataract. Of them in 2018, 245 still had cataract. And of them in 2019, 143 still had cataract. So we asked them, why are you not undergoing surgery? The center is close to you, it's free, we are doing everything, we give good service. The most common, they say, we do not have money to pay for a checkup, even though it is costing only 50 rupees and the surgery was for 3,000. Then they said some later is we have family obligations. Some say it is not a serious problem. And many say, okay, you say our vision is 660, but we are able to see adequately. So why we undergo? So we looked at the barriers over the years. So as they get older, money is a barrier. We looked across gender. Surprisingly, women said we have family or household obligations, so we cannot undergo cataract surgery. When we did across a 3-year-old period, and we say again, do not have money and obligations, stand forward. If we look at it across vision, even their vision is reducing. It doesn't make much difference to them. But the family business obligation does stay. Even if the vision gets lesser, they say, no, we do not have. We compared these barriers with other studies. But in most other studies, barriers are looked when people come to a hospital or they come to a camp. And then they are asked, why have you come late? Here we have gone in their community and in their homes repeatedly, and we have asked them why they are not undergoing. So here also you see cost is a barrier, and again, lack of escort, and it's not a priority. That's another barrier. So our study showed that neglect of eye disorders, it's not a priority for most people. It may be for us as healthcare providers. It's not for them as recipients. Financial barrier, even if it is a few thousand rupees, many people still consider it a barrier. There are social barriers because people have to do other things than do cataract surgery. And they are not sure if they do a cataract surgery, it will really help them in life. So we have to increase awareness. Yes, free surgery is still needed for a significant population. Social factors are very, very relevant. It's the first time we have studied barriers repeatedly across 4 years and seeing how they change. Well, surprisingly, they didn't change much. And in the end, I think we need qualitative research to understand why. Because we think if we give service close by, if we give service free, if the service is good, then, well, everyone will undergo cataract surgery and there won't be any cataracts left. But that's not the case. So I think there is still going to be a lot of cataracts for all our youngsters to do for a long time to come. So we have to understand why that is the case. Thank you.
Thank you so much, sir. Any comments by anybody? Thank you.
Thank you.
Next speaker is emotional distress in patients with neuroophthalmic disorders, use of emotional thermometers, Dr. Ajinkya V. Deshmukh.
Dr. Najwa was
Oh,
there.
I think.
Dr. Najwa is there? Sorry, she's before you. So you can,
Okay.
you have your presentation ready? Yeah, please.
A very warm good morning. I'm Dr. Najwa Sharan, final year postgraduate from Madurai Medical College, Tamil Nadu. Our study is an optic nerve head and retinal nerve fiber layer analysis in patients with alcoholic liver disease. Alcohol is the world's third largest risk factor for disease burden, and it accounts for 3.5 million deaths worldwide every year. Most of the mortality attributed to alcohol is secondary to cirrhosis, that is 50% is due to alcoholic cirrhosis. Significance of the study: understanding alcoholic liver disease retinal impact can aid in early detection and prevention of blindness and thereby ensure an improved patient care. Our primary objective was to investigate changes in optic nerve head parameters and retinal nerve fiber layer thickness in patients with alcoholic liver disease. And our secondary objective was to correlate these changes with liver disease severity score, that is the child Turgut Puig score. And our study was an observational study. Study group: cases were formed by 70 alcoholic liver disease patients admitted to the general medicine ward of Government Rajaji Hospital, Madurai. And controls were 70 age-matched individuals without alcoholic liver disease from the Ophthalmology OPD of GRH, Madurai. Study Center, Department of Ophthalmology, GRH, Madurai. Inclusion criteria: age more than 18 years and alcohol consumption of more than 50 grams per day for 5 years, and aspartate aminotransferase by alanine aminotransferase ratio of more than 2, and USG abdomen suggestive of fatty liver or coarse echo texture of liver were included as the cases. Exclusion criteria include age less than 18 years, refractive error of less than 6, more than 6, pre-existing ocular pathology, patients with any other form of liver disease, substance abuse other than alcohol. Methodology: all participants underwent a comprehensive ocular evaluation and OCT examination using Topcon 3D OCT 1 Maestro 2. Statistical analysis was done using Excel and Python, and a p-value less than 0.05 was considered statistically significant. And these were the key findings. Mean RNFL thickness and RNFL thickness in all quadrants were reduced in cases when compared to the controls. And this is the graphical representation showing mean RNFL thickness and RNFL thickness in superior, nasal, inferior, and temporal quadrants were lesser in cases when compared to the controls. And in optic nerve head, the average rim area was lesser in cases when compared to the control. Average linear cup disc ratio, vertical cup disc ratio, and cup volume were greater in cases when compared to the control, and all these values were statistically significant. And this is the graphical representation showing a reduced rim area and an elevated linear cup disc ratio, vertical cup disc ratio, and cup volume in cases when compared to the controls. This is statistically significant thinning of RNFL in all quadrants and an increased cup disc ratio, cup volume, and reduced rim area in cases when compared to the control, but this did not correlate with child Turgut Puig score. OCT can thus serve as a critical tool for detecting and monitoring alcoholic liver disease-related ocular damage. There's a need for interdisciplinary care between hepatologists and ophthalmologists is essential for the comprehensive management of alcoholic liver disease. RNFL thinning in alcoholic liver disease is consistent with findings by Alvarez-Cismero et al. In chronic alcoholics and Ahuja et al. In alcohol use disorder. RNFL and optic nerve head changes did not correlate with child Turgut Puig score. These align with the findings from study by Agdamir et al. Among patients with cirrhosis. Future direction: expanded cohort involving a large multi-center studies are needed to enhance the generalizability of the finding, and longitudinal studies are needed to assess the reversibility of RNFL and optic nerve head changes post-alcohol cessation or liver transplantation. We can also assess the role of therapeutic interventions like antioxidants and vitamin supplementation in preventing ocular damage. These are my references. Thank you.
Nice study. Thank you so much. Any comments?
I just wanted to ask if you would like to add any kind of neuroprotection in such cases if you identify optic nerve damage or retinal nerve fiber layer thinning.
Ma'am?
Would you like to add any neuroprotection to such patients if you identify?
Yes, ma'am, but this study was an observational study. So here we assessed the alcohol liver disease severity and how much damage was there in the retinal nerve fiber layer and optic nerve head. In future, it can be considered.
Because we have to settle down to the clinical relevance of a study if we are doing it.
Yes, ma'am.
So if there is anything as such which we have identified, then that would be, of course, the question if how we are going to intervene.
Yes, ma'am. We have considered as in the future directions.
Yes. Okay, thank you.
Thank you.
Was there any change in macular thickness? Have you studied that?
In this study, only the
Opening
RNFL thickness is
Macular
considered.
you did not study.
Yes. Thanks.
Is the next one.
Dr. Deshmukh?
Do we have the next speaker? Dr.
Dr. Deshmukh is
Yeah,
there.
Dr. Purna Chandra is there. Can have it ready there.
Hi, I have nil financial disclosures. So I want you to imagine a 35 years old IT professional presents to your OPD with severe vision loss due to atypical optic neuritis. You obviously investigate and treat her disease, but my question to you is, how often do you ask her, how are you feeling? How are you coping up with this condition? Frankly, you don't. And unfortunately, neuro-ophthalmological conditions do cause debilitating mental state, either due to the acute presentation, the chronic course, or at times due to grave prognosis. So with this study, we report our experience with screening for depression, anxiety, and distress in patients with various neuro-ophthalmological disorders using a novel tool, emotional thermometers. In this prospective study, we recruited neuro-ophthalmology patients more than 18 years of age who presented to us from July 23 to September 23. We excluded the younger patients, those who were already diagnosed with some psychiatric issues or were on some medications, the vulnerable patients, and non-English speaking patients. After confirmation of the etiological diagnosis, those who consented were enrolled in the study. Now you see, these are the emotional thermometers. Emotional thermometers are a short visual analog scale to screen the patients for psychosocial risk. Our patients tick this scale depending on their perceived levels of distress, anxiety, depression, anger, and need for psychological help. The cutoff value is more than 3 for first 4 domains, and any non-zero value for the 5th domain were considered significant, and the statistical analysis was done using linear regression and multinomial logistic regression. We recruited 60 patients with mean age of 45, ranging from 19 to 78 years. 55% were males. The most common presenting complaint was double vision or acquired squint in 47%. The most common onset was acute in 62% of the cases. The most common ocular manifestation was craniomotor nerve palsy in 35% patients. Other patients had papillitis, optic atrophy, neurological field defects, ocular myasthenia. On emotional thermometer scoring, if you can see, about 50% of the patients scored significant distress and anxiety. And it is noteworthy to see here that about 45% of the patients self-reported that they need some kind of psychological help to cope up with their current condition. And the overall incidence of emotional distress in our cohort was 53.33%. On linear regression analysis, the age of the patient and the duration of the symptoms did not show statistical significance with the estimated scores, whereas the need for neuroimaging, the patients who needed neuroimaging had the highest risk for having emotional distress, followed by those patients with acute onset of the disease and females. Now, emotional thermometers have established its validity and reliability across different subspecialties of modern medicine, and it has been extensively used in cancer patients to screen them for depression. Among ophthalmology disease patients, this meta-analysis shows the pooled prevalence of 31% for anxiety symptoms, but majority of these studies cater to the population of dry eye disease, uveitis, glaucoma. But there is scarcity of literature when it comes to neuro-ophthalmology, and our study is one of its kind. On comparison of emotional thermometers with that of other conventional scales what are used to screen for depression in hospital settings, emotional thermometers being visual analog are short, non-wordy, and very easy to understand as well as to administer. Our study has few limitations. We excluded the non-English speaking patients, and so we are trying to translate these scale into the local languages so that we can include those patients as well. We could not sub-analyze the patients with diminution of vision, monocular versus binocular, or depending on the severity of diminution of vision, and it needs a larger sample size. So our study signifies the usefulness of this novel screening tool, first time in the setting of ophthalmology. Neuro-ophthalmological disorders do cause significant emotional distress. As a physician and the treating ophthalmologist, we can help detect depression or anxiety and prompt such patients for timely help for their overall well-being. Thank you.
Thank you so much, Dr. Deshmukh.
Thank you.
Next speaker is Dr. B. Purchandra, he will speaking of variation in genes, genetics, and possible repair, Indian community perspective.
Dr.
So-
Suprita is there. Right.
So good morning, everyone. So as we all know, in the last 15 years, there are more than 500 disease-causing genes have been identified in the eye, and most of them is related to the inherited retinal dystrophies. This is the typical conversation which happens once we diagnose retinal dystrophies. You have retinal dystrophy. How do we cure this? Sorry, no cure. Can you do something to treat? Nothing to treat. You can use low vision aids or go for rehabilitation. Then patient will ask, will this condition pass on to next generation? You can go for genetic testing. Then patient comes up with a series of questions like, does my vision going to deteriorate? Will I go blind? Can I do something to stop the deterioration? Is there a possible therapy in the future? To answer some of these questions, these needs to be studied comprehensively in the Indian context. So with this, we began a study where we identified the families with inherited retinal disease, identified and isolated the mutations, studied these mutations in cell lines, and how to repair this mutation, and also we studied the effect of the repair. This was an observational study approved by Institutional Review Board. All patients underwent comprehensive evaluation, including imaging, and electrophysiological tests were done wherever it was required. For genetic testing, we used next-generation targeted sequencing using 240 retina-specific genes to look for the variations. Among 5,108 IRD patients, 524 patients opted for genetic testing. Among this, the predominant mutation what we found was ABCA4. However, the other mutations which are reported in the literature are also present. So coming back to my title, how this data helps us to understand variations, genetics, and possible repair. Let me explain you the case example. This was a 43-year-old female who had a macular atrophy. When he did a genetic testing, we ended up discovering totally new gene which was not reported. Incidentally, the symptomatic father and asymptomatic children were also carrying the same gene. When we screened the father, he did had a macular atrophy. The children were asymptomatic with 6/6 vision, near normal fundus, OCT was also normal. But if you look at the macular autofluorescence, there is an abnormality. So this is the OCT and autofluorescence across 3 generations with increasing severity. If you want to stop this progression, the only way is therapy. I'll come to it later. So this is one more interesting family where the 14-year-old female presented with foveal atrophy. When he did a genetic testing, she had a compound heterozygous mutation in ABCA4. Mother was asymptomatic with 6/6 vision, was homozygous for one of this mutation. However, when he did an autofluorescence, there were subtle changes in the perifoveolar region. So this is a typical example for same disease, same gene, same family, but the severity could be different depending on the mutation what they have, which is very common in Indian context. So to study the effect of these in cell lines, we used human embryonic kidney cell line. To make this simple to understand, the darker the band, the better the protein function. I'll explain it the case example again. This was a 13-year-old male with a V type of mutation who had a very mild disease. As compared to the second one, 9-year-old male who is 4 years younger to the first patient, had a Q type of mutation with a very poor protein function, he had a very severe early onset macular atrophy. And ERG was also telling the same story. In first patient, it was almost near normal. In the second patient, there was a severe rod cone system dysfunction. So how to repair this? So let's see what gene therapy can offer in this group of patient. So there are some challenges when it comes to producing clinical grade vectors in India. That's the reason the already approved gene therapy product, they costing crores, which most of the Indian patients cannot afford. 99.99% cannot afford. So these vectors needs to be produced in-house, which is a little complex process which involves transfection, harvesting, and it has to undergo multiple purification process. Even then the challenge remains. Some of the commonest gene what we find in Indian community like ABCA are very large genes which cannot be loaded into the single variants. That's why we came up with a novel dual vector strategy where we split the gene into 2 of, loaded into the separate variants. Once they are co-infected together, they reach the target cell where they are expected to function normally. So these were all produced in our own vector production facility, which is the first in India. And we used Stargardt disease mouse model. This is the mouse autofluorescence. As compared to the normal mouse, the mouse with the ABCA4 knockout has increased autofluorescence. Once we injected our dual vector, as compared to the treatment naive and also the mouse which received the control vector, the mouse which received our dual vector, there is a significant decrease in the autofluorescence. We went one step ahead and did ERG in these mice. As compared to the controls and the non-injected mouse, there is an improvement in both outer and inner retinal functions. So to conclude, I would like to say what was known was this is where we used to end. This is a dystrophy, nothing can be done. What this study adds is genetic sequencing and screening from Indian families, new genetic and phenotypic variations, and pathogenicity of mutations were studied, and animal models to study the effect of dual vectors were also studied. The next step is to start the human gene therapy. I have showed an example of ABCA4 gene. Since the sequencing and the vector production is done in our own facility, it can be done for any other genes. Thank you so much.
Have you actually done it in a few human eyes?
No, sir, this is just the animal
Right,
trial we have.
model.
That's why my future plan, based on this data, we'll be starting the human trials.
Right. And you've seen success in those
Yes.
animal eyes?
Yes, sir, definitely. As I showed,
Yeah.
the autofluorescence definitely decreased because we know that the ABCA4 results in excess lipofuscin accumulation.
Right.
Once we inject a dual vector, this disappeared. That means our gene is producing the protein which is able to digest this autofluorescence. And also we did ERG in this mouse because these were live mouse, where there is an improvement in both A wave and B wave amplitude as compared to control. Stating it's not only the structural improvement, there is also a functional improvement in this one, which is surprising. It is an added benefit.
How many cases? Like
The mice, sir?
Yeah.
No, we have used 60 mice, sir, in this one as a control and this thing as where they were injected. As a control, there were 100 standard mouse which are there. And we have a different mice for cell line. This, what I showed was a ABCA for knockout mice. Like that, we have a different model for RP65 and things like that.
And in almost all cases, you see an improvement?
Yes, sir. Yes, sir. It was an uniform response which was seen. There are few mice which developed like cataract, endophthalmitis and all. Those were excluded from the study.
Thank you so much.
How many days they were followed?
Sir? So these mice, we have still the 6 months follow-up. The ERG was done at 3 months. We have total of 6 months follow-up, and this mice which are able to survive, we are planning to repeat the ERG again.
Only one injection was given.
Only one injection given. That's our aim in human trials also.
Thank you. Next speaker is Dr. Suprita Kumarjian, and she will be speaking on Beyond the Night, Exploring Ocular Morbidity in Obstructive Sleep Apnea.
Dr. Shri Harsha is there? Right. You can have it prepared there.
Good morning. I am Dr. Suprita, here to present on the paper Beyond the Night, Exploring the Ocular Morbidity in Obstructive Sleep Apnea. So I will be discussing under the following headings. Obstructive sleep apnea is a very prevalent disorder, particularly in the adult population in India. And in this condition, there will be repeated episodes of upper airway obstruction, which will cause hypoxia and sleep disturbance. As we know, retina is the most oxygen demanding tissues in the body, and hence it is majorly affected by hypoxia. Some mechanisms were postulated. The important ones were the intermittent hypoxia can cause increased sympathetic response, which will result in higher oxidative stress. Also, we came across that endothelin-1 is a potent vasoconstrictor was released in OSA, which will cause endothelial dysfunction. So, aim of our study is to determine the characteristics of ocular characteristics in OSA and hypoxia-induced visual morbidity. So, we also try to highlight the importance of ophthal screening in this common disorder. So, our study was a prospective study done on a cohort of 156 patients in a period of 1 year. So, all the patients with obstructive sleep apnea who had come to our clinic and referred from pulmonology were screened. So, a complete ophthal evaluation was done, and ancillary investigations like OCTA was done as and when required. So, there was a male preponderance in our results, and also there was a higher incidence in the 5th decade. Out of the 156 patients, 18% had significant ocular complications, the most common being normal tension glaucoma, idiopathic intracranial hypertension, and keratoconus. There were other few included ocular hypertension, CRVO, central retinal artery occlusion, and floppy eyelid syndrome. So, there were many associated comorbidities. More than 50% of them had, the most common being obesity. The others were diabetes, hypertension, and other metabolic disorders which were overlapping. So, of the patients who had ocular complications, we noticed that 1/3 of them had significant visual loss. Though normal tension glaucoma was the most common in our study, the vision loss was comparatively lesser as compared to keratoconus and ocular CRVO, which had a higher visual loss, and maximum being in CRAO. So, ancillary investigations like OCTA was done in patients who we suspected who had retinal pathology. We noticed that there was retinal vessel density was reduced and blood flow to the choriocapillaries was also reduced. This suggests that there is a microvascular damage in the retina due to OSA, and this can potentially affect the vision. So, there was some detailed literature review we did. And the most common in literature was NAION and floppy eyelid syndrome. However, we did not come across that in our study as common. And there was others like keratoconus and central retinal retinopathy, which had varied prevalence. In our study, keratoconus is one of the higher occurrence. And glaucoma was the most commonly seen in our study. So we understand that normal tension glaucoma was more common than ocular hypertension. This can be due to global decrease in blood flow. So it will decrease both the aqueous production and drainage. Hence the IOP is normal. But however, hypoxia will directly affect the retina and the optic disc, leading to glaucomatous damage. And idiopathic intracranial hypertension, we came across an interesting study where the CPAP therapy could potentially reverse the IAH. And this further aids the link between the two conditions. So I conclude by saying that in our study, we found that there was significant retinal vascular insufficiency in OSA patients due to both structural and functional changes in both the inner and outer retina, contributing to impairment in vision. So we emphasize that ophthalmic screening is very important in all the patients with OSA to look for the above mentioned ocular complications. And also obesity is becoming more and more common in today's sedentary lifestyle. Hence we again seeing more incidents of OSA, and hence there should be vigilant screening. Thank you.
Thank you so much. So, besides normal tension glaucoma and ocular hypertension, you've seen other cases also in these?
Yes, sir. We came across IIH and keratoconus were also commonly seen.
Keratoconus, has this been reported earlier also with the obstructive sleep apnea?
Yes, sir. Previous studies also have shown, but there has been varied prevalence in different studies. It is not most commonly seen.
Any other ocular problems besides these?
We also, I mean, in studies, the most common was the NAION, sir.
Right.
We are going to do more investigations to see, but in our cohort, we did not come across.
Right. Thank you so much.
Thank you.
Next speaker, Dr. Shri Harsha Lanka.
Can I have the presenter's view on? Yeah, thank you so much.
Do we have Dr. Hirika there? Right.
Okay, very good morning to the August House. I bring greetings from Port Blair. As we all know, orbital compartment syndrome can have devastating outcomes through compromised vascularity and compression of optic nerve. The common causes include intraorbital hemorrhage, tumors, and thyroid eye disease. However, I stand before you to present a rare cause of orbital compartment syndrome and even more interesting progression in this particular case. Our patient is a 55-year-old gentleman who is a father of service soldier who initially underwent an uneventful cataract surgery in the first eye. He was operated in the second eye with pre and intraoperative period being uneventful. However, on post-op day 1, he had severe headache and ocular pain, proptosis, ecchymosis, and limitation of extraocular movements with visual acuity of 6/60 with RAPD being present. Within the next 20 minutes, the patient had rapid deterioration to just perception of light. That's what his vision. And this was the eye appearance. And with a clinical impression of possible retrobulbar hemorrhage, he was taken up for an urgent CT scan and shifted into the gantry of CT within the next 10 minutes. To our surprise, there was no blood in the orbit on the CT scan, and positive findings included proptosis and posterior tenting of the globe. While the CT scan was being acquired, his vision further dropped to no PL inside the CT gantry. Sensing an ongoing active rise in the intraorbital pressure, he was immediately shifted to the OT for decompression. In the OT, immediate lateral canthotomy and cantholysis were undertaken. This led to a dramatic on-table return of PL while the patient was still on table, and the patient confirmed that the light had returned. Within a few hours, the acuity improved to 1/60 and remained so for throughout. He was admitted and managed with high dose of intravenous steroids, topical moxifloxacin, IOP-lowering drugs, lubricants, and homatropin. The corneal edema, which the patient had resolved over next 4 days, and it is when we noticed CRAO in the patient. He was given all possible measures to control CRAO, which was too late by then. However, he was also offered hyperbaric oxygen therapy of 4 sessions, which yielded no response. However, we see in the patient that there was a return of PL, gradual reduction in proptosis, and some visual recovery. However, the enigma remained why the in the absence of retrobal hemorrhage, what caused the such a severe orbital compartment syndrome. So literature was reviewed, and a probable hypersensitivity to local anesthetic mixture was considered, and the patient and his family were counseled for hypersensitivity testing. We waited for 8 weeks so that all the steroid in the system is metabolized, and intradermal prick test was done. For the test, the volar aspect of his left forearm was injected with normal salinous control, plain lignocaine, and mixture of lignocaine and hyaluronidase. In this particular patient, bupivacaine was not used by the resident who blocked the case because it was unavailable. The same stock of both drugs were used for testing as used preoperatively. Until the time the testing in this suspected case was used, we seized all this particular batch of drug, and we didn't use in any other patient. 10 minutes post-patient, it was injection, it was evident that the culprit was indeed hyalase. It can be from bovine, ovine, or recombinant human source. The incidence of allergies is known but very, very rare. It is commonly used in ophthalmology and intra-articular and caudal blocks injections. The presentation can be acute, early, intermediate, or delayed. The presentation may simulate in a variety of different presentations also, and it is thought to be of type 1 or type 4 hypersensitivity. To conclude this case, we've come to know that hyaluronidase allergy can have devastating sequelae. Primary sensitization, as in this case, through the first eye, might have been a trigger in the second surgery. Though the benefits of the drug usage outweigh the risk, we have to be extremely suspicious in such kinds of presentation in post-operative scenario. The importance of this case is we owe the answers to the patient, and if possible, hyalase should be avoided for regular use, especially in this age of topical surgeries. This was, of course, a resident case, so we did use it. And meticulous documentation may protect against any litigation in such scenarios. These are my references. Thank you so much.
Thank you. So the surgery was done under peribulbar?
Yes, sir.
Right. And the patient was patched?
Patient was patched.
And it was opened the other day, next day?
Yes, sir.
And there was vision when the patch was opened?
There was vision, sir. In fact, it was continuously dropping. We somehow explain it by the patch was somehow preventing any edema due to external pressure. When it was opened, it was in the range of 636, 660, and over the period of minutes, he started decompensating.
A little unusual.
Unusual, sir. So I went through a few articles. They told that in the articles, it is known that it can evolve over a period of few hours also. So maybe overnight it was fine. Early morning onwards, he started having headache and periocular pain. Right. That was the reason to present this, because it's quite unusual, and even the most dramatic aspect was the moment we did cantholysis. The patient said within 1 minute, "Sir, मुझे OT का light दिख रहा है." So that was something.
So maybe there's an allergic reaction to. I mean, it's usually acute or subacute most of the times.
Yes, sir.
So maybe there could be.
It might have been evolving overnight, and it was lucky that we could spot it.
Maybe could have been some other reason as well. Maybe.
So it was not noted in other patients of the same OT.
Right.
There was no skin reaction. Correct. It was not betadine. It was not Tropica Plus. Right. And that is why the skin testing was there in presence of the HOD of the dermatology department. Right. So
maybe something like an insect bite or something like that.
Unusual. It was patched eye. So the eye was patched overnight. So very unusual, and that too in the only operating eye. CRAO presenting. It was really a compressive neuropathy.
Compressive, right. Yes. Thank you so much.
Thank you, sir.
Thank you. So
next speaker, Dr. Rika Gosala.
Very good morning to everybody. I'll be talking about Scrub Book, a perfect surgical DG logbook for every resident. So, do we all remember our first day in the OT, our first cataract surgery? I mean, the comments that were given by our trainer, why we were so nervous about it. So yes, obviously, I mean, that must be one of our most important day. And the important question here is, how did we perfect our surgical steps and tackle those complications? So how I did it in my residency was I used to document all my surgical details and the complications in a Excel format on my iPad, and wherein I had the demographic data, the surgical data, all the complications, and then the steps that were assisted by the seniors, and the steps that I did, and the steps done by the seniors. And over time, I realized that my complications reduced a lot only because of the fact that I documented and I could review my cases, and it helped me improve. We also did Oscar grading for every case, wherein the trainer used to score us for every step of SICS. And I think even that really helped us improve, because we would know exactly which step is the step that we require more training and we need to sharpen our skills. So over time, I realized this could be a really tedious job to record all surgical data, especially if you're working in a high volume center. Trainer cannot moderate it exactly because you might be documenting it, and it's difficult to review it as a whole. So there's a hackathon that happens every year in Arvind Hospital, Pondicherry, and that's when we came up with this app called Scrubbook. So this is how the Scrubbook app works. So the trainee has a login ID, and they will add a patient data wherein the entire MR number, details of the patient, the demographic data, date of surgery, the anterior segment diagnosis, posterior segment diagnosis, this eye operated, pre-op vision of the patient, pre-op astigmatism, post-op undercorrected vision with pinhole, post-op astigmatism, complications intra-op on day 1, day 30, what could be the reason of the complication, the steps that were assisted. You can even upload a video link of your surgical surgery video. So in this way, the trainee could exactly put in everything, how we put it in our Excel, but in the app format. And you could view all your surgeries at a glance in one go. So while for the trainer, they also have their login IDs, wherein they'll form their account, and then they can review, they will have an account wherein they can put Oscar grading for that trainee, and they can review their log IDs, like what are the patient's complication on day 1. So this is how easily it could happen for both the trainee and the trainer just through an app. So the aim was to evaluate the app's usability, effectiveness in tracking surgical performance, and its impact on residents' learning and confidence. So 20 residents from various years of the training were participated in this study. And at the beginning and the end of the study, the participants completed the surveys wherein they assessed their previous experience with surgical logbooks and their expectations from the app. They were also asked to rate the app's ease of use, usefulness, any improvements that they felt were needed. And at the end, their qualitative feedback was collected. This included the number of surgeries logged, the time spent, the frequency of feedback requests from mentors, that was to check the efficiency of the app. And in addition to collecting the qualitative feedback, residents' self-reported confidence level in their surgical abilities were compared before and after using the app. This comparison helped us assess whether the app had any impact on the surgical learning curve. So the results were app usage, and over the course, at least 15 surgeries were logged in the app. Average time taken was approximately 5 minutes, indicating that the app was both time efficient and user-friendly. Majority, 90%, used the feedback feature regularly and requested post-surgery feedback from their mentors, which was highly appreciated. Resident confidence and learning showed significant improvement. 50% rated their confidence in performing as high after using the app. Additionally, residents reported feeling more aware of their surgical progress and areas requiring improvement. Mentors also reported that the app facilitated more structured feedback and enabled them to monitor the residents' progress. They noted that the ability to review the surgical logs in real time helped them. And also there were a few areas where we need to improve on was the surgical checklist or a more detailed analysis and delays in the app. So it is a handy go-to app for every resident or trainee, which can be used as a digital surgical logbook. Trainee can easily store patient-related data, record any records can be put in, and all complications can be reviewed at once. Can be moderated by the trainer, a surgery link can be put in, and even the Oscar grading can be done. And future prospect is to introduce statistics for all complication, alert notification on exceeding complication limits or recurring complications, surgical lessons by experts for complication management, taking it beyond cataract and for further other specialties, and to hire an expert surgeon to advise to grade trainee cataract surgeon. So I'd like to conclude by saying that this could be really useful for all residents. Thank you.
Thank you.
Thank you so much. We are running
Short of
late,
time.
actually.
Next speaker is
Yeah.
Dr. Swati Upadhyay.
Dr. Hemant is there. Right. And we have Dr. Mansi Tripathi as well. Right.
Respected judges and my friends, my topic is impact of comprehensive AI for screening diabetic retinopathy, AMD, and glaucoma in vision centers. I have no financial interest. As we all know, the three leading causes of blindness worldwide are diabetic retinopathy, AMD, and glaucoma. And vision centers are the first point of contact for people in the rural areas where their patients are screened and referred to higher levels of care if needed. But the drawbacks remains there are limited expertise of the mid-level ophthalmic persons, the resource and time constraints, and increasing burden of eye diseases in aging population. So we found out a smart solution where we use Medios AI, 3-in-1 AI, which takes care of diabetic retinopathy, AMD, and glaucoma. So these three were separately tested in 3 different prospective studies where we validated DR with a sensitivity of 93 to 100% and specificity of 86 to 92. The glaucoma AI was validated in our base hospital where we found the sensitivity of the AI as above 93 and specificity above 80. And the AMD was also validated and the sensitivity was over 90. So the purpose of this study was to evaluate the impact of integrating this comprehensive AI in just one click in vision centers of tertiary hospital in Pondicherry. It's a retrospective observational study which involves 3 vision centers which were using the AI to the maximum, and it was divided into 2 phases. First phase was before the implementation of 3-in-1 AI and after implementation of AI. So before implementing 3-in-1 they were using either AMD AI or either glaucoma AI separately. So what was like random patients were selected either when they have diabetes or when the sister found that it is AMD. So they took the fundus photo on the fundus on phone, and then the offline Medios AI 3-in-1 AI processed the image, and then it gave a diagnosis as referable or non-referable, and either it is referable for AMD, DR, or glaucoma. All were taken into consideration. The images were verified by the teleophthalmologist at the base hospital, and whether the teleophthalmologist felt referable or the AI felt referable, all these patients were referred to the base hospital. So we had a 30,315 patients. In the pre-AI 3-in-1 AI, we had 14,903, and in the post 3-in-1 AI, we had 15,412 patients who were seen and they were like at the vision center. Specialty referral to the base hospital was noted. So the overall referral to the base hospital increased from 15.58 to 17.55%. In that, the retina referral increased from 14.1 to 18.9, but the glaucoma referral decreased from 15.1 to 14.4. The retina referrals were statistically significant. This is showing the follow-up rates after implementation of the 3-in-1 AI, which shows that glaucoma follow-up decreased, but the retina follow-ups increased after implementation of the 3-in-1 AI. So as I was told, the referral patterns showed increase in both the modalities, the retina as well as glaucoma, but there was a follow-up was decreased. So retina referral and follow both increased, but glaucoma referral and follow both decreased. So these are the studies which I am showing comparison of Medios AI and other studies with diabetic retinopathy, and the software showed significant good specificity and sensitivity. So I would like to highlight that our sample size was large, and this is the first of its kind of impact analysis study, but the limitation being it's retrospective, and we need to evaluate individual patient level referral rates alongside overall referral rates as compared to AI based only and AI plus teleophthalmologist based referrals, and we need to conduct severity based analysis for referrals to the base hospital. To conclude, comprehensive AI screening transforms eye care delivery, and it helps in precision disease detection, but in resource constrained settings and also time constrained settings, and it also increased patient engagement in care pathways. So I would like to highlight why the retina referrals was increased, because the patient could see their own the diabetic retinopathy on the fundus photograph, AMD on the fundus photograph, and they could understand better that this is going to be vision threatening and I need to go to the base hospital earlier. But in case of glaucoma, they were not having so much of visual impairment when they were screened, or when they were told you have glaucoma or you are a glaucoma suspect. They didn't take it so seriously, and also the better part was the more number of disease, the glaucoma suspects, the false positive referrals were decreased by using the AI. So it was both a win-win situation for retina, but not a win-win situation for glaucoma. On one hand, it was decreasing the false referrals, but on the other hand, we were not able to convince the patients that, okay, your fundus photograph is showing suspicion or glaucoma, please go and visit the base hospital, because their vision was good at the time of diagnosis. So we need wider implementation of AI augmented screening programs as a sustainable, scalable approach to address global eye care workforce shortages and substantially reduce preventable vision loss at population scale. Thank you.
Thank you so much.
Thank you, sir.
We have the next speaker.
Dr. Hemant.
Good morning, everyone. I will be talking on the clinical outcomes of minor salivary gland transplantation for severe dry eyes secondary to chronic Stevens-Johnson syndrome. We will be going through the introduction. As we all know, SJS is a complex immunological disorder involving total body surface area less than 10% and predominantly involving oral mucosa and conjunctiva. It is an MB-spective interventional case series done at RP Center of Ophthalmic Sciences, AIMS, New Delhi. All the patients with chronic SJS having severe dry eyes, severe aqueous deficiency, the Schummer scores less than 5, and in the bilateral patients, the worst eye was taken, and minimum follow-up was 1 year post-surgery. All the active infective patients, ulcerated patients, perforated patients were excluded from the study. It is a short video, which I will be showing later. In the post-operative medications, moxifloxacin, prednisolone, and lubricants were given, and betadine and chlorhexidine gargles were given. Coming to the results, the mean age of patients in the study was 28.6 years. There was 12 female and 8 male patients, and 60% of the patients found allergic to antipyretics or analgesics. Other causative agents included anti-epileptic drugs, anti-tubercular treatment, and 10% patients had unilateral ocular involvement. Maximum patients were having the disease duration of in between 5 to 10 years. There were 6 patients who have the duration for the less than 5 years, and 4 patients between 10 to 15 years. All the patients showed significant improvement in BCVA, Schummer score, hyperemia score, keratinization score, and SPK score. The p-value was very significant. All was less than 0.05. It is a post-operative image at 1 year of follow-up with improved corneal transparency and wettability and reduced neovascularization and keratinization. Again, it is a clinical photograph of patient showing both pre-operative, it is a dry surface, there is a lot of keratinization, and in post-operative phase, there is improved wettability, and we can see cornea a lot better. We can see the improved lubrication in the eye, degrees of superficial punctate keratitis or epithelial defect. Hyperemia was significantly reduced in these patients. The advantage of minor salivary gland transplantation include this procedure improves wettability, reduces inflammation. We can see the improved Schummers, reduced hyperemia, reduced conjunctivalization, neovascularization, and corneal opacity score. Biosimilarity of TS and saliva with conjunctival oral mucosa leads to lower immunological reactions. And there is easy availability and easy accessibility and universal availability of the process. and there is low risk of allogenic rejection as it is an autologous graft. My limitation of my study include lack of subjective evaluation and quality of life analysis, and there is lack of immunohistochemistry to demonstrate the viability of transplanted glands. So minor salivary gland transplantation is a viable and effective treatment option for cases of severe dry eyes secondary to Stevens-Johnson syndrome. In future, the randomized study could enhance our understanding and applicability of MSGT in managing severe dry eyes secondary to chronic SJS. SJS is not a common disorder with many variables in natural history of the disease. Thus, conducting a randomized study in this patient may be extremely challenging. Here are the references for my study. I will be going back to the video and showing it to you. So the excision area of the lower labial mucosa was marked approximately 15 cross 15 mm, and it was infiltrated with 1 to 2 ml of 2% lignocaine, and the superficial incision was given with the help of 15 number blade. Deeper dissection was carried out using the scissors, and we explanted the gland. Minimum 12 to 15 number of acini should be present. After that, we opened the conjunctiva and placed the gland and secured it with 6-0 silk and 9-0 proline suture. Thank you.
Thank you so much. So we have the last speaker, Dr. Mansi Tripathi.
Start the timer, please. Good morning, everyone. So I'll be talking about intralenticular lens aspiration and fibrin glue-assisted IOLs in Marfan syndrome. So ectopia lentis is a key ocular feature of Marfan syndrome and the leading cause of visual impairment in these patients, the management of which may be either surgical or conservative. However, as we know that zonulopathy in Marfan syndrome is often progressive, therefore in young patients, endocapsular rings themselves or by fixation might not always be sufficient, and in such cases, scleral fixation of IOL is a viable option. However, SFIL is particularly challenging in Marfan syndrome due to the thin sclera and higher risk of posterior segment complications. Most of the studies in literature have studied sutured SFILs in Marfan syndrome. However, we chose glued IOL. Why glued IOL? Because it completely eliminates the suture-related complications such as extrusion or breakage. It does not involve the structural manipulation of the IOL haptics as seen in flange techniques. Fibrin glue also enhances the adhesion between the scleral flap and the underlying tissue. A recent study by Lee et al. Also found that younger patients and sutured IOLs are at a higher risk of breakage and redislocations of SFIs. And since Marfan's patients are younger at presentation, we would like to prefer a sutureless technique in these patients. Therefore, and moreover, intralenticular lens aspiration glued IOLs have not been previously studied exclusively for Marfan's patients. So with this objective, our primary outcome was to assess the post-operative CDV at 12 months of these patients and to note the interoperative complication, residual refractive error at 12 months, and post-operative complications by the 2 years of post-operative follow-up and any additional surgical intervention required. So this was an ambispective observational study conducted after due ethical clearance at a tertiary care center. These are our inclusion and exclusion criteria. One thing I would like to highlight that we only included confirmed cases of Marfan syndrome which were diagnosed after they fulfilled the modified Gens criteria. So this is the study timeline. We caught the patients, we recruited them from the post-operative follow-up in the lens clinic, and retrospective review of their records were done, and they were prospectively followed up till the 2 years of post-operative period. And once they completed 2 years, the data was noted and it was analyzed. So these are the results. The baseline parameters, as you can see, that the axial length is slightly longer and the keratometry is slightly flatter as we expect in patients with Marfan syndrome. And 4 out of the 44 eyes, and 3 of the 44 eyes in our study had cataract and lattice iris degeneration respectively. After the surgery, as expected, there was a mean increase in the mean post-operative CDVA at day 1, 3 months, and it continued to increase till 12 months. And the MRSE, we were able to achieve near emetropia with a refractive scale of 1.2. 66% patients had no visual impairment after the surgery. Among the complications, I would like to highlight that vitreous hemorrhage was one of the most common complications of our study. And among the other complications, we also saw one case of haptic extrusion, which we usually don't expect in glued IOLs, but since these are marfanized with thin sclera, there was one such case that we managed by fixing it in a new tunnel, and one case of haptic slip and dislocation. And one of the interesting findings in our study that we found was we tried to correlate the final CDVA with the presenting age at 12 months. And what we found was that the younger the patient were at presentation to us, the worse was their final visual outcome. This moderately negative correlation was statistically significant. So we further divided these patients into two groups, aged less than or equal to 10 years, which were 25 eyes, and older than 10 years, which were 19 eyes. And we found that even though initially their mean presenting visual acuity was comparable and CDVA at 1 month was comparable, most of these patients had amblyopia, and the group older than 10 years tended to have better visual acuity at 3 months, and it continued to increase at 12 months. So both these observations, they tell us that patients who present younger with ectopia lentis, they have severe degree of subluxations and severe and deeper amblyopia, and therefore their visual prognosis is guarded. So the key points to take away from our study is that CDVA improved after intralenticule lens aspiration with glued IOLs with minimal complications for ectopia lentis and Marfan syndrome. And although the post-operative day 1 and 1 month CDVA was comparable in both the groups, children aged 10 years and younger, they tend to have poorer visual outcomes. And there was a moderately negative correlation between the age of presentation and the final CDVA at logMAR. That meant the older the age of presentation to us with the diminution of vision, the more likely the patient was to be closer to logMAR 0. So the limitations of our study was we had 44 eyes in our study, and we would like to have a larger sample size to increase the generalizability of these findings, and a longer follow-up period is required, which we are continuing to follow up our patients. We have 2 years follow-up, and we would like to see how stable they are at 5 to 10 years of follow-up. And fibrin glue also increases the cost of surgery. So to conclude, intralenticular lens aspiration with glued SFIL is a useful modality for ectopia lentis associated with Marfan syndrome, and although the anatomical and refractive outcomes were similar, younger age of presentation is associated with poorer visual outcome. Therefore, counseling is necessary. Thank you so much.
Thank you so much. Right, so we conclude the session, and we are late by 15 minutes or so. We have a quick photo session. All the speakers may come over the dais, please, and the panelists, and we hand it over to the next panelists for the next session.
Thank you so much,
everyone.